Jim and Mitchell, so if you could please introduce yourselves a little bit further, and perhaps Jim can give a history through his own experience of large U.S. consultancies in mergers and acquisitions. So Jim, please go ahead.
Thank you, JP. A little bit anecdotally, but just a little bit of history to further the introduction and maybe set a little bit of context. But in the example that JP gave, we actually met even prior to that time. So, imagine meeting under healthcare IT circumstances 20 years ago. It was the beginning of the Office of the National Coordinator, and it was the beginning of health information exchange as we know it now. It was just prior to the time when phones got smart and actually had apps on them, so it was prior to that time. And when we were working on the pilot that JP was talking about, one of the gentlemen that was involved in our kind of tight-knit group of folks that were working on federal and commercial, really ideation of what this was all about and applying technology, one of the other gentlemen, if you remember, Dr. Michael Cowan, was involved with us. And back in 2004, 2005, Dr. Cowan's most recent retired position was as Surgeon General of the Navy. He was in charge, he happened to be in charge of the deployment of federal medical assets during the unfortunate 9/11 attack. So with that ideology being involved and JP's perspective globally from IT, my perspective in years long being in hospital information systems and trying to get data to be shared, Dr. Cowan's perspective of the most extreme, immediate, real-time circumstances of trying to acquire, manage, and distribute data in that type of situation made for a really, really interesting consortium early on. And then I was also fortunate enough to be involved, I think, in the first International Academy of CIO meeting here at George Mason. So I'd like to acknowledge JP and congratulate JP and the other executive directors of the Academy for bringing us all here. Over the years, really quickly, I spent a great deal of my time in hospital information systems. I spent my time in laboratory information systems, which is really where I started to cut my teeth on large-scale data integration. And then fast forward into the 2000s, where it became a need for the best effective type of approach to healthcare delivery was to aggregate as much information as possible and use it in an effective way, both from a population health perspective, but also on an individual health perspective. So being involved in that type of integrative technology over the years, and now being here at this point in time, where 20 years ago, we didn't even have smartphones. And we had to carry our x-rays across the street from, an x-ray clinic to your doctor's office and to your hospital, and you were lucky if that was the only place you had to carry them to. Right now, we're essentially totally integrated, and now we're using the advantages of artificial intelligence to help us diagnose diseases, to help us manage the information, and to help make some suggestive some suggestions on how to, number one, use the data, how the doctors could help doctors make diagnoses, and make sure that we do that as effectively, as safely, and as trustworthy as possible. So bringing us up to today kind of brings me full circle with JP and GMU and what we've done over the last 20 years. So I'm very, very happy to be involved in this level of AI discussion, public health policy, which always impacts whether you're on the commercial side or public sector side of healthcare. They are both intertwined and they're both codependent on their success. So I think that's an important part of our conversation today to keep in mind as we're talking about how AI is advancing and helping us in health IT.
Two other quick notes about the pilot project. Dr. Hazel was part of it also, and tremendously helpful. And Jane Woods, who sadly passed away, but was Secretary of Health for Virginia too, prior to Dr. Hazel. But one of the more interesting parts of it, so we had several chief medical officers from hospitals on the group, with the group too. And so we had a discussion of how much data would the emergency room physician really like to have about the patient. And so initially we thought it would be quite a bit, like a year or 2 years. It turns out that they wanted very little from a time frame standpoint, a month or two, and that was all they were going to look at. And a lot of it was really focused as to whether someone was at risk of bleeding and that type of thing. So they had very focused questions and very small amount of information from a time frame. And they would use it. They primarily wanted it for if someone came in who was unconscious, and they would have it and be able to have a baseline for the patient. So with that, Mitchell, if you could please introduce yourself.
Sure. So Mitchell Goldburgh. My career spans over 40 years in healthcare, but I started, and I'm going to leverage some of the things that were just described. One of my experiences was working at Loral, which became Lockheed Martin, and to JP's point, one of the things we were developing was a digital dog tag for people in the military. And as you said, it was all about the triage of the trauma. I didn't need to know if you had measles, didn't have measles, that whole history. But that became the tool which integrated healthcare, because if you were, the vision was, first of all, no one left behind, right? Which is for all the sacrifices that our troops make to keep us safe at home and have these forums. But more importantly, the trauma care that was given in the battlefield would be documented and updated in the digital dog tag, so when they get to the tents for subsequent treatment, that would be updated. And then when they were airlifted and get back to Walter Reed or one of them someplace in Germany, they would have the entire history of the trauma care, right? That was, again, very specific and very minute in terms of the overall health of the patient. It didn't give you what an image gives you, which is an image is worth, what, 1,000 words or something, as they say. So I worked on a health information exchange for pediatrics. Because, again, big difference between interfacing and interoperability. You know, it's a small vessel. It's a small fracture. What does that mean, right? So putting up the picture, and this was around pediatrics, and the Central Alabama Health Information Exchange, about the same time you were talking about 2004, 2005. So now we were exchanging images across private care and hospitals in Central Alabama. It brought to light the fact that, again, you could be interoperable under these things that are non-standard standards. You know, HL7, DICOM, Digital Image Communications in Medicine, all sorts of freedom to put things into numbered fields so you know what's there, but what you put in that field became very hard to interpret. It also became very hard, now that the information was exchanged, where do you put it in the systems that the doctors and patients and nurses are using to track their information? So I had all that experience and brought myself through surgery and digital pathology, and so color imaging is a whole new science and a whole new language of ambiguity, although that's debated by pathologists, right? They're very specific, and as are the imaging specialists in general. The end story, though, is that having access to the entire patient record when you have vertical silos is only exacerbated in public health, right? It's exacerbated because of the people who are using emergency trauma clinic centers, which aren't necessarily connected to anything, and trying to get that public health care to be a patient-centric record is one of the many things that we're going to talk about today. It's great to have artificial intelligence, but artificial intelligence built on a foundation of legacy systems, no systems, paper systems, and other poor infrastructure will miss the expectation on the adoption of AI, and that's what JP and I and Jim are going to explore today.
Thank you both. One other really visual example, pre-computer, was the File for Life. So Secretary Woods promoted this across Virginia too. It's a little pouch with form that you attach to your refrigerator. And the idea is if the emergency tech comes in and you're unconscious, they would go to the refrigerator and have it. Virginia especially promoted this to many seniors, and many seniors adopted it. But what also happened, anecdotally, but a little bit more, some citizens in Virginia didn't put their own up there. They had that file for life for their dog, and they had it up on a refrigerator, and so in case something happened to the dog, someone would be able to come in. So that's another very visual example, and a second one is Dr. Hazel example, someone that's ill, sometimes with a rare disease, but sometimes not, and they go from doctor to doctor, and each doctor they're given the clipboard and that they need to fill out. So another visual example of where some of this interoperability occurs. So for our discussion, for both of you, how should we define healthcare and health for the discussion? So Jim and Mitchell, or one of you.
So it's interesting, health is all-inclusive, right? Health is all-inclusive. Sometimes mental health has a physical cause, right? Sometimes mental health is just depression. But it could be a lack of vitamin D, it could be all sorts of things. So health and its, the care of that health is very complex, because the difference between an aging healthcare versus a healthcare from trauma versus a healthcare for a specific disease versus just homelessness, right? All of these things come together, and challenges that AI can't overcome unless we have an infrastructure that can help bridge it. So to answer your question specifically, it's not the vibrancy at 68 that I feel tomorrow, but it's everything that goes with it. My mental health, the physical health, the environment I'm in, and the challenges that some rural areas don't have internet today. I mean, the lecture we heard 2 moments ago about the whole country being digital and every patient having, every citizen having a unique ID number, that is just, that's phenomenal, right? And a fundamental to being able to provide whatever healthcare is described as.
And I'd further that in terms of a definition, how I look at it systemically. Health is a condition, health care is an action. How do we manage, how do we proactively manage and address within the healthcare environment? And that goes from an informatics point of view, and it's physical activity. It's how is your clinician addressing your condition and the overall situation in context with the information that they have at hand. Our job as informaticists, as technologists, is we may not necessarily be clinicians, though many of us are, but in the position of being an informatics expert and being within clinical IT, our job is to give the clinicians the best tool possible, whether it's the information equivalent of a scalpel or a stethoscope or what have you. Our job is to make sure that we give you the most up-to-date tool you need to be informed immediately on how you're going to deliver health care to the condition of health of the patient or the population that you're looking at.
Thank you. A topic that Dr. Gonzalez raised a little bit earlier. Across your experience, are institutional health challenges with AI different than public health?
I'll jump in quickly first on that one. There's some fundamental differences here. And first is the interpretation or the perception of AI. And actually, I was particularly in tune with Alan's presentation a few minutes ago because I've been dealing in public health, governmental health at the Fed and state and local level for an awful long time, concurrently and never not concurrently with the commercial end of how healthcare is applied. The preparedness and maturity of your organization to be able to deal with, especially at this point, AI, and it goes to Mitchell's point, what's our infrastructure like? And part of the infrastructure is actually knowledge, preparedness, awareness, and readiness to deal with AI. Alan's presentation was spot on, essentially in terms of you really need to recognize what level of maturity and capability your organization is currently at, and recognize where you need help. recognize where you may or may not be ready yet, and what tools or what preparedness do you need. So from that perspective, AI in public health versus commercial health, I have found it to be AI in public health. We've got a lot of public servants in jobs that are underfunded, overworked, understaffed. How do I get AI to help me just get my job done? And that could mean anything from clerical to clinical, concurrently, both at the same time from start to finish. You could be one person running a county-based public health office that also has to interface with hospitals and with clinics and deal with the patient that's in front of you or the group that's in front of you to try and deliver some sort of service to your healthcare, to your population, to your public health population. Conversely, if I'm looking at that from a commercial side, more often than not, we are embedded in the IT work of delivering better value, faster, and more trustworthy to a clinical audience. But at the end of the day, the common thread between both of those is how are we making life better, more healthy for the patient, and how are we helping the folks that are delivering public health better, whether it be just doing my job better, quicker, faster, more efficient, or on the healthcare delivery side, how do I deliver better health to the patient for better outcomes on an individual and a population basis while making my job as a clinician, a statistician, or a clerical person easier, meaning more efficient, but also more effective.
Thank you.
So if I can just posit the following. There are institutional health care, and I appreciate your difference between health and health care, isn't public health, right? There are a lot of portions of our population that don't go to institutions. They don't like institutions. Institutions are bad places. Bad things happen to people that go to the institution because they never come home. Public health is for all of those people that, including those that go to institutions, and so it has a much broader challenge, right? There were people that will only go to the grandparents. There were people that will only go to family. I don't feel well, I need some chicken noodle soup, as it wasn't the case in my house. Aunt Frances's chicken noodle soup killed everything. The same time, one of my friends grew up on a farm upstate New York. It was called man or beast medicine. Came in a blue apothecary jar. If you were under 6, you got 2 tablespoons of milk and 1 tablespoon of the elixir. If you were a cow, you got all 3 tablespoons, right? So public health deals with a lot of common practices, beliefs, and challenges that AI is not going to solve, right? It's the adoption of technology and the adoption of institutional things. We've done some horrible, horrible practices over the history of the United States, and I'm not trying to get political here, but I'm just saying people who are new to the United States or people that are indigenous to the United States have not always benefited from institutional care. That's still, it was on television on Sunday, on Good Morning, Sunday morning, what used to be Charles Kuralt, now it's Pauline, I can't, what's her name? Anyway, it doesn't matter. The point is they were showing the Native Americans that won't come to hospitals. They won't participate in studies. The reason this is so important, and I'll tie it off here, is artificial intelligence has to be trained, right? And artificial intelligence trained in institutions produces completely different results than artificial intelligence trained on public health data. So it's not perfect, and the healthcare we have today isn't perfect, but the ability to train data on non-institutional information, if it's wrong, multiplies. It's not like 10% wrong, and then the next algorithm that makes a decision on that wrong data is 10%, it's just 20%. It's 100% wrong. It's a multiplier of that bias that you have in your data. So we love this opportunity, JP, to talk about artificial intelligence. Couldn't be more excited, but it's not a panacea. There's a lot of challenges that come with it.
Thank you. I'm going to go off script and then come back to the script later a little bit. So I'm going to ask Mitchell, what is the state of art in AI in medical imaging? And Jim, what's the state of art in AI with medicine in general? And then a second question, which might not be up on the specifics, but more in general, why has there been such difficulty with some of the AI systems with early sepsis diagnosis, such as the EPIC one?
Sure.
Yeah,
So I'll start on imaging. So there are radiology, diagnostic imaging has led the market space, largely because the access to ground truth is there, and healthcare screening plays such a critical factor in managing public health, right? Early detection of diseases can be done very simply without AI today for mammograms and chest x-rays and other common things that you do at some benchmark level, 40 years and older, 50 years and older. The predictive nature of AI in medical imaging is still not multimodal. You still need a doctor to say, oh, you have this genetic marker. Oh, you have this history in your family. Because the AI today is simply looking at the single study. So it's coming. There's over 1,200 FDA validated, not FDA validated, but FDA listed algorithms that have been validated on populations. And the value-based care in Europe, far greater adoption than we have in the United States because it impacts and measures the outcome of patients, especially in healthcare screening.
thanks.
I think so. With following right on the back of that, there's a common theme with, for example, what Mitchell's talking about in AI, recognizing different points and signals. And more of them than a human can actually comprehend right at any given time. That's value. That's a lot of value in helping out with the diagnostic end of what we're doing. Using the example that JP brings up is a really good example of pros and cons, or pros and or missteps with how we've analyzed against sepsis, for example. Sepsis is a clinical condition that could progress quite quickly. When you're in a hospital setting, for example, you could come in to an acute care setting and be, relatively healthy, meaning that you're coming in for a certain condition, but while you're in the clinical setting, something happens that you may be either preordained to or vulnerable to or exposed to a situation where you could contract sepsis, and of course that could be a fatal situation as well. On the pro side of that, and we're still, and from my non-clinical opinion, I think clinically we're still trying to build the efficacy of how we use AI in this particular example. There's, for me, as an informatics person, the value in AI is being able to take snapshots frequently and in real time of things like labs, of things like images, where an AI perspective could look at many more different points and signals and figure those out, even if they might not be relative now. It gives us the ability to raise the flag that says, hey, at 2 o'clock, we had a lab with this result and an image that had X number of points. It doesn't mean anything now, but in a predictive manner, we need to watch this again in 30 minutes because there may be a tendency for this condition to lead to the next level of criticality in a patient's need for care and in a patient's condition. So I think that a great evolving benefit of AI in that particular instance is how much data could we look at, how quickly and how frequently to come up with a predictive set of analytics that says this patient is vulnerable for X, so we could proactively say, we've got to move this patient out of this area, we've got to treat this patient with a different medication or a different medication therapy, so in 3 days he doesn't end up on a ventilator in ICU.
Yeah, but I think there's also the danger of AI and some of the Gen AI. So there's lots of AI, right? AI is like cars or good meals, right? It's a very broad term. There's AI that's doing target recognition or pattern recognition, right? And so we have social determinants of health. I'm sure that's been discussed in many of the clinical forums, certainly with the clinical forums where I speak, and how does that impact patient care? Social determinants of health, creating more data, because now I'm categorizing people, and someone has to oversee that categorization because there's biases in the social determinants of health. Once you get beyond that, you have tools that assimilate data, right? To Jim's point, I've got a lab test, I've got a chest x-ray, I've got all these signals, what is all of that doing? Or, as Alan said, and he wrote a book using Gen AI, right? Writing formats and coming up with things. And now we have these electronic health record systems, like the Epic that JP was talking about. It is volumes of coded data. Volumes that humans can't interpret. There's more, and there's a clock. I don't know if any of you have seen your primary care physicians. They're under the gun in these institutions to see you in less than 11 minutes. Code the visit, then put it into the system and be on to the next patient in 11 minutes. That's not health care, right? That's just observations for something later to do. And they're treating symptoms, not the cause, because they're focused on this cataloging of information. AI can help. Here's a great example. It's called ambient listening. It listens to the conversation, and through an algorithm that someone trained, selectively picks out phrases and puts it into electronic health record. So now somebody else, for your doctor, is putting things into the medical record for them to then make a diagnosis from, which only creates more work for the primary care physician, because now they have to make sure that the ambient listening put everything that need to go in. So again, not a panacea, right? And automation, everything that you said, Jim, 100%, but there's still a lot to go in understanding where's the best application, and because of those fears, like I have to now reread what this AI told me was the right thing to say, it's just creating more work, which is the barrier to adoption.
And just one thing additionally to that too, the other advantage that AI is giving us is in things like social determinants of health and all of the coded information, the volumes of coded information, which is discrete. We'll refer to that as discrete information and non-discrete information. A lot of social determinant of health information is non-discrete, meaning it might not have a coded value. It could be contextual background on the patient's living conditions. But how do we ethically interpret that and train AI to ethically interpret that to make it relevant to a patient's condition is all because of the speed to value, and how we can train AI to do that is another advantage that AI gives us in dealing with non-discrete data or volumes of coded data where we've got to try and collate it as quickly as possible to be proactive about treating and getting ahead of the patient's condition.
Thank you. A colleague of Dr. Gonzalez's works with, actually a former student of hers, a researcher at NIH, and he's a glioblastoma expert. And so what he's doing is he's mapping omics information to brain images with the idea of training the AI to be able to infer omics information just from an image. Like methylation status and stuff. So of course one of the main issues is lack of data and how to put the data together. So what are some of your thoughts on data scarcity and how to come up with this type of data that would be truly helpful with AI capability? Not for glioblastoma specifically, but I mean more in general.
So it's the patient's data, right? It's about the patient. But care decisions and outcomes and administering of tests and the delivery of healthcare is the intellectual property of the institution, right? So you own your data, it's your data, but the institution has best practices. They have all sorts of standard operating procedures on if you come in with a broken finger, what are the steps, what's the best way to care for it. That said, there are ARPA efforts under ARPA that NTT has participated in. There's other areas and companies that have been set up now to build upon large foundations of data that have been de-identified. So technically speaking, you can't say that this is Mitchell's head exam. You don't know it's Mitchell's, but here's a great example of data challenges. It was discovered, so there's a imaging science called CT, which is an X-ray that you sit in a sphere, you go through the tube, and it takes a axial view of your image instead of a chest X-ray that's planar. If you were to, and this was a college student out west did this, if you were to take the grayscale and make it very plain, you could drop that head CT into Facebook and find the person. Now, it's been de-identified. There's no name, there's no machine, there's no hospital where it was done, there's no location. But if you play with the pixel data just enough, the algorithm in Facebook was good enough to identify the person. So now the de-identification means you have to blur some of the images, some of the parts of the images at a certain extreme grayscale. Well, then, if you're making a judgment on a calibrated image and training on a predictive, can you do it on a blurred image? I don't know. It's one I'm not scientific enough to say, but it was fascinating to see that you could manipulate the medical images and drop it not into some fanatical AI thing on Facebook and find the person. So challenges come in access to information. There are trusted research environments that are set up so the data never actually leaves, and NTT provides that service to life sciences and some AI companies, but it's still constantly looking for ways to make sure that it's de-identified, but subsequently that I have a representation that's true to the population upon which the AI is being applied. There's an RFP out for Ireland for breast imaging. They only want algorithms that have been running in Ireland for years so that they can prove that the women in Ireland are different than the women in Florida. I don't know how that goes, but the point is you always want to test your algorithms and validate it and train it on where it's being used.
I think I'm going to ask one or two more questions and then open up the questions. So the FDA has approved many AI applications, and they've all been locked on the data that they were trained upon. And for the most part, they've been pretty narrowly focused, so non-diagnostic, non-recommending treatment, so really adding to medical care. And there's a FDA pilot several years ago with the idea of accrediting the producer. They had like 10 companies, like some little, and then some very big like Apple. So accredit the software developer, and then there would be a lower bar for approving the AI application. And so some were in favor of this type of approach. Others, including one of John Paul's colleagues, who I met at a conference that John Paul co-organized about a month ago, was a little bit skeptical of the whole approach. She was a ethicist at NIH. But what are your thoughts about FDA approvals of AI, and what should they be looking for, and what are some of the considerations?
I think right now I'm involved in policy discussions, both that are impactful from a state and federal level. AI at the moment is in its youngest stages, even though what we know as AI right now most immediately is probably all of 2.5 or 3 years old. AI has been around for a lot longer than that, right? But in healthcare specifically, the excitement, interest, and enthusiasm around AI is just about 2.5-ish or so years old. And interestingly enough, one of the comparisons I use about where we are with AI right now versus where we were 20 years ago, for example, AI is ahead of the curve in terms of how do we regulate it, and there was a good comment earlier, what's the difference between guardrails and guide rails, right? One of the positions, for example, that HIMSS happens to take from an informatics point of view, and I'll be very general about this, but information available that I could share with everybody if they're interested. It's important for us at this moment to allow AI enough room to breathe, pun intended, and not turn down the regulatory screws too tightly. First of all, from a regulatory position, we don't know and never will. This is an evolving specialty around AI. We shouldn't turn down the screws so tightly that it eliminates the efficacy, the usability of AI. If we have to jump through so many flaming hoops from a clinician's point of view and a systemic point of view to either be careful, constrained, constricted, and really covering your bases in an over-accentuated way, the efficacy and the benefits of the value of AI is going to be drastically degraded. So one of the positions that we're taking kind of as an industry is we need guide rails, but the guardrails should not be overly tightened at the moment because it'll destroy the efficacy of AI. So from a regulatory point of view and from JP's question with regards to the FDA, the FDA is involved in regulating and certifying medical devices, for example. Over the last, especially 15-ish or so years, the FDA has also been involved in certifying software as a medical device when it has a certain level of involvement with your clinical approach and your clinical approach to care and caregiving and diagnostics and so on and so forth. I heard a comment just this past week on one of the business shows. AI was described as we're in the top of the third inning of a 9-inning game, and it's taken us about 3 or 4 years to get to the top of the third inning. So our AI awareness, our AI appreciation and respect for what AI can do is really in the youngest stages, if you will. So we have to let the industry breathe. We have to let our scientists and clinicians breathe and lead what we need for AI, and as informaticists, we'll be there to support it. But as far as the policy end of it, we also have to lend our voices to policy. We have to lend our positions to policy. So the state governments, the federal governments, FDAs, whatever that branch of government needs, we have to make sure as informaticists and thought leaders here in the industry, if we have the opportunity to make a stand and put our voices in play in this, that's a really important part of collectively, I think, what everybody in this room has a place in as well, but us from healthcare specifically. So that's not a definitive answer to your question, but it's an evolving answer.
And I just want to make 2 quick comments. One is there's a missed expectation, right? We sit on the internet, some of us use the internet in our daily lives, and what trade shows in healthcare are available in 2026? ChatGPT gives me a list based on this whole new industry called prompt engineering. It's amazing, right? How you ask the question. We've almost lost the innocence of a child, how they ask the question versus how your professor tells you, JP, I know I have a test today, and how you ask the question of your professor. If you ask Google, where's the nearest Starbucks, and it tells you it's on 17th Street on the left-hand side, and it's on the right, no big deal, you still get your coffee. If you ask AI in healthcare, where's the tumor, and it says it's on the left lung and it's on the right lung, it's a much bigger problem. So those of us that are aware of the advantages of AI, right, always are pushing, isn't there an AI for this yet? And there isn't, because it's science. It's not just information, it's pure science. So the second part is, all of it, the AI that we are involved with today and that's being used because the internal review boards of hospitals have approved it and FDA has approved it, they're all labeled purposes. So mammograms, which is a very common screening study, can't be used on women that have breast implants because the algorithms haven't been validated unless the breast implants are moved out of the image. great example, but it's a labeling. It's like you can't take 15 to leave, you can only take 2 every 12 hours. Same kind of labeling comes from the FDA. I just wanted to illustrate what the FDA is doing.
I'm going to ask one other really quick question, and then we'll have questions from everyone. From an industry structure standpoint, to what extent do you think that the EPICs and the very large health information exchanges, that a lot of AI applications for doctors will be through their services, and that there'll be somewhat of a gatekeeper? And to what extent do you think it'll mostly be other medical service providers and smaller companies and working in tandem with those large ones?
Good question, right? As we know, the Epics, the Oracle healthcare centers are, several of the biggest, and, I'll get dinged for not mentioning, the 7 others that might be in the top 10. But that's a very, very good question, because just as a matter of math, those bigger companies control, and maybe control is not the right word, managed is a better word to say. They manage a majority of the healthcare information that flows through, in this instance, through the United States. But they're such great companies and such big companies in terms of the amount of information that they have access to and manage. We can't just scale it against the information that's available in the United States. We can scale that against information that we could garner from the rest of the clinical patient information that flows through these systems. And I may not be exact in how I'm describing this, but for example, some of the larger EMR companies that work around the globe have access to populations of data from different ethnicities, different geographic locations, all of which have their own certain aspects and characteristics to healthcare for that region or healthcare population, but there's also a lot of common threads. One of the greatest advantages that those companies bring to the table, because they are so big and because they do such a great job on managing volumes of data, is they could bring this data to a head anonymously and say, we have a population of data, not just from this state in the US, not from this region in the US, but from this ethnicity background globally. And let's put all of the data elements and the data metrics on the table and see how we could sort them out using AI. There's no way we could address that volume of data manually from a humanistic point of view in a linear fashion. We've got to do it concurrently, aggregately, and kind of all at the same time. That's what AI brings to the table for us, but that's the importance of having the big EMR companies be so advanced and so capable of dealing with reams and populations, literal populations of data to bring to the table so we could gain scientific and medical knowledge from that in an appropriate and ethical way.
But I think this goes back to the opening question. My colleague was talking about institutional care. Electronic medical records are institutional. Public health, there are going to be all sorts of crazy grant-started startups, innovations, college students. There's a trade show that Jim and I go to, and you say, well, where was this piloted? Where did you do this home health monitoring? Well, I used it on Grandma and Grandpa, and I'm looking to raise $10,000 to take this tele-something system somewhere else. So I think there's a lot of room that will not crowd out the AI, but it gets back to your earlier question, JP, of where's the data to train it, right? The other thing that we need to understand is, as we all get old, we come from a Japanese company at NTT Data, and in Japan, the inversion of the people of age versus the people to take care of them is disproportionately upside down. So we're racing in Japan to figure out ways to augment care at home, to take care of the elderly, to collect information because they're not in institutions. Socially, families are living vertically and taking care of their parents at home, and how do you collect that information? Again, innovation, even in countries like Japan, the Aboriginals, we have NTT in Australia, and all of the native tribes down there, they're not institutionalized, and there's an obligation, a mandate that they need access to healthcare. So I think there's a lot of opportunity for people that are very creative to have access to all sorts of intelligence that can be called artificial to help people organize information and take care of public health.
Thank you. Do we have any questions for Jim and Mitchell? Jean-Paul, or Dr. Gonzalez, please.
Yes, I think you make the point. It's important to make the difference between healthcare and public health. It's different domain. We're taking care of a patient. We're taking care of the population. Different objectives. So the final objective now for us, practitioners and working at the hospital, it's to go to the personalized medicine. Each patient is unique. So do you think artificial intelligence will step into this huge domain? You were talking about genetics. Yeah, we are. So one patient, one medicine. What do you think?
Absolutely. So the answer to that is unequivocally, from at least our seat, I think yes. AI has the ability to help us with a genetic-based approach to personalized medicine, precision medicine, if you will, both from a care perspective, a care management perspective, and specifically in an acute care situation when you're dealing with trauma or some sort of operative procedure. How are we going to use very personalized genetic-based medicine that AI helps us sort through to deliver personalized care? So I think that's how it's currently being approached. It's evolving as we speak, but the answer to your question is yes, absolutely. AI is going to help us do that.
And I would just say too, it's one of those ultimate views of precision medicine. If we're in the third inning, precision medicine is like top of the ninth, right? So we're still in my personal opinion, is that we're still in the mode of creating more data and identifying more data that can lead to personalized medicine. But we're not at the point where AI is multimodal, right? Meaning taking different elements of data to give you a decision. That's still left to the human, right? So we've got a lot of data and a lot of journey or a lot of ball game to get to before we're ready for precision medicine. That said, there's definitely treatments and vaccines that are specific to races and diseases and family histories that you should be careful of, right? That's a different thing than I think you were speaking about, but still it's a ways away from AI.
Bijou, please.
Yeah. So on the cost side, right, healthcare is very expensive, more expensive in US than some other places. On the cost side, actually from operations point of view, how can AI help? On the cost side, from operations point of view, how can AI help?
So I'm going to be careful with this answer for a number of reasons because it is so deep, right? There's several rabbit holes we could go down in this. As simply as I could put it, AI will help us not only with cost, but with better care because it's speed to value. And again, we could have an entire weekend seminar on what makes that a valid statement. But utilizing AI to really analyze and get into predictive analytics about a healthcare condition so we could get to the root cause faster and get ahead of a patient's criticality getting worse or deteriorating. AI is going to help us get ahead of that. AI will also help us with the business end, and this is we definitely have to draw a distinction with the business of healthcare in the United States versus the business of healthcare almost everywhere else, right? Profitability drives the business of healthcare in the United States, but this is, and again, my personal opinion too, if we learn how to appreciate, utilize, and train AI to help us with making healthcare better, that will actually help bring down costs because we're not misdiagnosing at the end, not because AI is diagnosing, but because AI is assisting the doctor in diagnosing correctly, more thoroughly, and faster, and getting ahead of a patient condition. So there's also AI applied to business algorithms, right? That has nothing to do with clinics, and clinical and medical care, but it has everything to do with AI analyzing the business end of healthcare just to make the business run more efficiently, which is very codependent on how healthy the patient is or isn't. There's a balance. There's obviously a number of tipping points in there depending on what you're looking at any given time. So my general answer is yes, AI is going to ultimately be very helpful in creating better healthcare, creating a better business model for healthcare, which ultimately is going to help us bring down cost.
It's not a panacea. AI is not free. So if I'm applying AI, I've got to take cost out somewhere else. If you look at the socialized systems or the national health systems like Canada, there's 3-4 weeks, even longer waits for imaging studies, complex imaging studies. AI can speed that processing up and give you more capacity, so it's impacting healthcare, but in America here, that's just more charges against your annual premium, right? Likewise, one of the impacts of AI is through the specificity of what it sees in the image, you can reduce the downstream testing because the algorithm gave you this is a negative, not a questionable study. So I don't need a biopsy because I'm telling you this polyp in this endoscopy study is benign. So again, lowering your cost of healthcare because the downstream costs of, maybe I'm going to err on the side of caution. You can reduce that and in doing so, increase capacity. So you're, again, especially with healthcare screening, reducing the false positives gives you healthier patients, less care, and you don't have enough physicians anyway to do it, right?
And reducing and repetitive and unnecessary tests, right? Exactly. The access to information and, again, AI helping us manage that. Guess what? I just had a chest x-ray 3 months ago for, could have been a routine chest x-ray, but I've got an image on file somewhere. I don't have to do it again. That's another example of applying AI to gathering information that it has to have access to begin with and, compiling and aggregating that information and directly applying it to reducing cost, but reducing unnecessary testing, for example.
Okay. So with the speed, like the rate of discoveries that are coming out in the medical and health field, and with all of the new research that's coming that's showing us that we've made like maybe erroneous deductions in the past, how is that being incorporated into the AI to keep it up to date, that we're always getting accurate results with how quickly everything is changing in the industry?
I think so systemically, I don't know that there's no silver bullet for that, right? It is environmental within a learning environment of high tech and delivering medical care. But I think it's kind of all our responsibilities to, from our seats to make sure that as technologists, as doctors, as scientists, to contribute from our seats to make sure that we update that when we can. Training AI is an evolutionary approach.
New training at all times?
Oh, absolutely.
Okay.
Just like yourself, right? Consider yourself, and it doesn't matter what level of professionalism you're at, how many degrees you have, we're all in an environment where we're constantly learning. If everything was static, we could declare victory one day and say, yep, we know everything that we need to know because there's nothing else to learn. That's not a practical statement, nor is it a practical position to take on AI.
Yeah. Just one quick. So there's multiple types of AIs we've talked about. The one I want to point out is the software as a medical device is not continually learning. Software as a medical device collects the deviations from the ground truth, meaning the pathology report or the actual outcome, and then they have to go through the FDA with incremental releases. There's other algorithms like coding and billing and counting of things, which gets training on an ongoing basis, social determinants of health rerun, and they find new things that need another deviation monitor to do things. But software as a medical device, if you go in and ask your doctor which version of this vendor are you using, is it the latest, they should say yes. but it doesn't mean that it wasn't, that was updated yesterday. It could have been,
Right.
it could be 2 years old.
Yeah, okay. Thank you.
Each perhaps make a closing comment. That would be great.
Sure. Again, I'd like to thank everybody that's at this conference. One of the things that we were talking about today, actually in several conversations, I think the unique takeaway from this environment is just how many world thought leaders, global thought leaders we have with us in the room and access to this online, just because of this format. And even though we're talking about multiple types of industries, IT industries, our common thread is data and information, leading us to how we apply in a ethical and applicable way AI to our end result. And the algorithmic approach to that is very much shared across industries. There's different specialties, there's different industries, but the logic and the progression that we're applying to that, and I'm learning about this every day. The conferences that I attend, I learn more about it every day, especially here, because of the diversity in the input and the contributions that we've had today. There's a common theme of data accuracy, efficacy, being ethical about it, and then how do we help AI learn to help us do what we do. So this has been a great opportunity to be here, and I thank JP and the Academy literally for having us here, speaking today. Thank you very much, and thank you all for your questions. And we will be available, afterwards if you'd like to get in touch with us. JP has our contact information on any information we deal with as we can. We're happy to share it with you. From a public policy point of view, we're involved in HIMSS to an extent, which is an ear to the rail and thought leadership in terms of public policy nationally and internationally, actually. So we do have access to other sources of information, and we're happy to talk with anybody that wants to talk with us afterwards as well. But thank you, JP, and thank you, everybody.
Thank you.